you very much, ladies and gentlemen. Today is my great pleasure to present our progress into our PhD thesis, which is focused on the new insight into risk assessment in gastroenterology. My name is Jakub Hoferica. I am a physician from Slovakia, and I came here to pursue my passion, which is science, with the vision to promote evidence-based approaches in gastroenterology by better understanding the risk factor in this field. For this purpose, we choose these two specific goals to pursue. First one is focused on the investigation of the relationship between acute pancreatitis and chronic liver diseases, and second one is focused on the application of fecal microbiota transplantation in alcohol-related liver diseases. So let's speak more about my first project. Here we focus on the effect of chronic liver disease on outcome in acute pancreatitis. Both of these diseases are very common in gastroenterology, sharing several risk factors and etiological factors predisposing them for concomitant outcome. Furthermore, CLD is associated with several conditions and comorbidities predisposing the patients for worst outcome. However, the exact nature of this relationship is unknown, and that's why we would like to focus and explore it more. For this purpose, we conducted these clinical questions. How does the presence of chronic liver disease influence the outcome in acute pancreatitis? The populations are all the patients with acute pancreatitis, and we are comparing those with and without chronic liver disease. And our primary outcome is mortality, and we hypothesize that indeed the presence of chronic liver disease is a risk factor for these patients. We conducted a systematic search in 2022. We identified nearly 50,000 articles, 37 of them were eligible. So here you can see our primary result, which is in-hospital mortality, expressed in relative term in odds ratios, where we compare the patients with and without chronic liver disease in the populations of patients with subgrouped by the stage of the disease. So cirrhosis and steatotic liver diseases consist of patients with alcoholic liver diseases, MASLD, NAFLD, etc. But you can see that these patients had overall a higher chance of in-hospital mortality, with odds ratio 2.57 times higher in the population of CLD patients. This was also mathematically significant. Also, we observe higher tendency for mortality in patients with cirrhosis. However, this difference wasn't statistically significant. In this project, we evaluated many other outcomes like local and systemic complications, etc. However, for brevity of the time, I cannot spend much more time with this. So the strengths of this work are that this is the first meta on this topic. We have large sample size and diverse populations. However, there are several limitations, namely the small number of prospective studies, relatively large heterogeneity that could not be challenged with subgroups or other approaches because of the reporting in the current literature, and no data on viral hepatitis and rare causes of CLD. In conclusion, CLD is a significant risk factor in patients with AP. These patients require more attention during the disease of acute pancreatitis and more intensive monitoring. Regarding the research, we need more prospective data, focus on the role of the infection and possible specific therapeutic approaches such as early or prophylactic antibiotic treatment in this specific population. Currently, this manuscript have been submitted to the scientific reports. We submitted our revision and eagerly awaiting the response from the journal. So now let me focus on my second topic, where we focus on the application of fecal microbiota transplantation in alcoholic-related liver diseases. Currently, in the world population, 4.8% of general population suffer from alcoholic-related liver diseases, usually in the form of steatotic liver disease. Out of those patients, 10 to 35 will develop alcoholic hepatitis, which is a very severe form of this disease, associated with high short and long-term mortality in these patients. Currently, we have very limited pharmacological treatments. Basically, we are relying only on the prednisolone, which has very small effect size and only in short term, no effect in long term. However, with advance of microbiota and our understanding of microbiota, a novel pathophysiological model of this disease developed, emphasizing the role of gut microbiota and gut-liver axis. That's why we would like to investigate the application of fecal microbiota in these patients. So we postulated this question: does the fecal microbiota transplantation improve the survival in this population? We would like to focus on the whole spectrum of alcoholic-related liver diseases, so steatosis, alcoholic hepatitis, and also cirrhosis. Our intervention is fecal microbiota transplantations, and we are comparing to standard of care. Primarily, we are interested in the survival. And we hypothesize that fecal microbiota transplantations indeed improve the survival in these patients. So we conducted a search last year in 3 main databases, identify nearly 13 articles included in this study. So, and here we come to the results part. First of all, I would like to mention that the available data provide information only about the very specific population, so patients with severe alcoholic hepatitis. What you can see here is a Kaplan-Meier curve that was created from estimates of individual patients' level data from specific Kaplan-Meier curves in the articles. As you can see, the FMT was associated with better survival at our primary outcomes, so which was the 28 and 90 days survival. So in next steps, we calculated from this data the hazard ratio for these populations. And as you can see, the patients receiving FMT has double the change of event, meaning dead in this case. And this was also mathematically and highly clinically significant result for us. In the next steps, to validate these results, we calculated and separate hazard ratios for each study and pull them together in meta-analysis, and we see that we receive very similar effect size, meaning that further validating these studies. Here in this plot, I would like to show you an survival probability in 28 and 90 days. You can see that patients with receiving FMT had an better outcomes and better survival probability as compared to the patients receiving standard of care. But what I would like to highlight is a quite big heterogeneity in standard of care patients, as you can see. And this is mainly the result of many types of treatment. So some of the patients receive pentoxifylline, which is currently not widely used, or they receive only nutritional support, etc., or glucocorticoids. So currently, this is the first meta-analysis for investigating the FMT and its effect on severe alcoholic hepatitis. We have a relatively large sample size and patients' level data from Kaplan-Meier curves. However, there are some limitations, mostly that there is only one RCT, and rest of the data are from retrospective studies, which unfortunately did not adjust for important confounders. And also, the only 2 countries are involved in our pool. So, in conclusion, FMT significantly decreased the mortality in patients with severe alcoholic hepatitis. This intervention should be considered as novel treatment for these patients, and the centers dealing with these patients should consider and establish reliable sources of FMT. For future, we need more high-quality randomized control trial focus on this topic. Furthermore, we need more studies focus on the specific bacterial species that could be causally related to the worse prognosis, or to the pathogenesis and pathophysiology of severe alcoholic hepatitis. Also, we need to have a reliable and safe guidance on the application of FMT. Currently, this work is in manuscript writing status, and I am working on my discussion right now, and we are aiming for the Journal of Hepatology. So, my first project currently is under revision. My second one is in article writing, and we would like to submit in the beginning of September, and hopefully have a luck. My additional activity is that I attended several international conferences, also the national one. I managed to meet very interesting Nobel laureates. I got work experience in CTM and co-authorship several papers. Thank you for your attention, and I would like to also wish you great many mistakes.
Jakub, very nice presentation, very nice ideas. So before starting discussion and exchange our thoughts, could you explain, because I think we're not experts in FMT. Probably due to time reason you weren't able to explain, but just for starting the discussion, could you explain how, what does it mean in FMT? Could you explain us?
So we are taking the sample of fecal matter from healthy patients, and we are introducing it to the SIG1. We can usually do it by either placing the nasojejunal tube and introducing it with the upper gastroscopy, or we can do it like colonic irrigation. But like that's the idea is to introduce an healthy microbiota from healthy humans to the SIG1.
Okay. Like in chronic, in CED patients, probably? Yes.
Thanks. Nice presentation, Greg. So, my question is related to this second topic. And the first question is also related to this. So, does it matter how this fecal microbiota transplantation is done? So, there are different procedures, as you mentioned. So, from nasoduodenal or from the colonic route. So, did you do such subgroup analysis regarding to this question?
No, because surprisingly the protocol for FMT was quite similar among all the studies. So usually they use 30 grams of fecal matter diluted in 100 milliliters of water, and they apply it via the upper gastroscopy.
I see. Okay. And my second question is, what kind of changes the gut microbiota has in alcoholic hepatitis? So how does it change, and what points could be improved by fecal microbiota transplantation? So you also wrote in the last slide that the bacterial species and the metabolites have to be checked, but what is known today about this dysbiosis? So what are the changes in alcoholic hepatitis?
There are shifts in specific species in these patients. However, the exact causal relationship of these species to the severe alcoholic hepatitis is unknown. It's hypothesized that actually these specific species, together with disrupt gut barrier, and together with immune system in the liver, are basically facilitating a higher inflammation rate in the liver. But however, there are no conclusive results so far. So only I can mention the articles that I saw that they identify specific species of microbiota associated with more severe alcoholic hepatitis compared to a healthy population, but I cannot tell you like.
So only the abundance of some specific strains changes in this situation, or the phyla and the ratio of the major phyla, so the Firmicutes and Bacteroidetes changes. So are there major differences in the gut microbiota also affecting the ratio of the major phyla in the colon, or only some particular bacteria change here? So what do you know about that?
So as far as I know, but my knowledge of the microbiota is limited, but as far as I know from my articles, there was increase in specific files that also shift the proportions, but we also try to pool actually this data as well. However, because of the very heterogeneous nature of reported data, it was not possible. Because all the included study that actually examine also the microbiota itself reported it in somewhat different manner. So for us, this was then impossible to pool.
I have questions regarding your control group. What is the standard of care for those patients? Because I saw like all these studies fecal microbiota compared to standard of care? Was it the same in all these studies?
No, no. Some of the study use as control glucocorticoids, some of them use just pentoxifillin, and others just nutritional support without the pharmacological treatment.
All right, and may I ask, why did you choose 28 and 90 days survival as an outcome?
So those are conventionally used in the other studies, so that's why I also choose them for my outcomes.
So congratulations. I think it's important especially to inform a medical society about this therapy. As I see, you have just a few studies. But I would like to ask about the first topic. You didn't have much time to show us other results, so can you maybe somehow summarize them for the complications? Thank you.
Oh, thank you. I just showed the overview that there were so many results, but in general we can say that also the rate of local complication like acute necrotic collection, pseudocyst or acute fluid collection were much higher in the patients with chronic liver disease. Also the rate of organ failure like respiratory, cardiac or renal failure as well.
Could you show us the result, please, from your second project with the two Kaplan-Meier curves? Yeah, this one. Okay, so how is your explanation for, you say it's a severe acute hepatitis. What is the definition for these patients?
So for severity, we usually use the MADRS score, and above 32, we consider it as severe alcoholic hepatitis. And the definition of alcoholic hepatitis is like acute liver failure with onset of jaundice and anamnesis of alcohol intake longer than 6 months. But no, I don't remember the exact criteria right now, but there are specific criteria for this. So in the studies, how they usually define them, some of them actually perform a biopsy. So it's biopsy proven that there was a severe inflammation and the presence. Rest of them use the conventional clinical criteria, usually based on NIIA guidelines.
So my gut feeling is a little bit scary. Because if we talk about a patient with liver problems, it can be from acute liver failure, he's dying in 2 days, or acute or chronic with a better prognosis. So if I see this, it's very nice data and it's also significant, but my gut feeling is a little bit, is it okay to put all the patients in one group? What is your gut feeling?
Oh, I would, some study actually report only patients with acute and chronic liver failures. So you can see the Akurva Panda, that was like trial from India, and they include only patients with acute liver failure. Rest of them either exclude those patients or use the combination. So this is like limitation of the study, that the population is quite heterogeneous. We try to conduct analysis including only patients with acute and chronic liver failure, but because of the nature of the reported data, that is not possible currently. So maybe when we have a future RCTs, we can perform such analysis, but currently I cannot give you an answer. But we can see on the plot that patients with acute and chronic liver failure had worse survival than patients than compared to rest of them, the last study, the Akurva Pande.
Could you go back to the Kaplan-Meier analysis? So could you please explain, because here I can see a significant p-value, but if I look at the FMT and standard of care, I see an overlapping confidence interval.
Yes, so the confidence intervals are for survival probability. So when we look here on this plot, you can also see that confidence intervals are overlapping between each study. However, when we take to account the entire follow-up of the patients in hazard ratios, then we can see that the result was significant. And you can see it also here that the confidence interval when we pulled all the studies do not reach the line of no effect.
It's a very interesting topic. Could you go to your last slide with your consequences from the data? Yeah. So what is your tell us more about the next step. What is your next idea? What would you like to do?
Mm-hmm. So I think this treatment should be definitely more investigated, especially in certain populations. So for example, in patients which are glucocorticoid not eligible, or because there are some contradictions, or they are not responders. Such population would be actually very great population for RCTs and to test this treatment thoroughly. Based on high risk of bias in our studies and high heterogeneity, I am a little bit cautious to promote this as like end question. But I think this should be considered in these patients, but with caution.
What is your idea about, because nutrition is also very important for the outcome. What is the idea to standardize the nutrition in those patients in the future?
Yes, the nutritional support is absolutely must in these patients. Actually, it's probably the most important part of as far as I understand, the guidelines got very general knowledge. Maybe more personalized approaches could be better, but I think that's for future studies.
What about antibiotic treatment?
Yes,
do you have an effect on your bacteria?
That's a very interesting question, because many times actually the glucocorticoids are prohibited because of ongoing infection, and that's I think very interesting question to consider whenever the FMT would be improved or worsen with antibiotic treatment, etc. So that's a very nice idea to consider actually. But I don't have any data currently in my literature that would be...
About FMT, how's acceptance of FMT in patients?
Oh, so as far I never indicated, so I don't know. But based on the literature, for example, the one RCT that was conducted, they are specifically mentioning that 3 patients out of 60 refused to continue the trial when they found out what exactly does it mean. So, but I think if we can explain the benefit to the patients, I think they should understand, and especially if we understand that, if we explain that this is very beneficial and it's becoming more and more used, I think they should understand.
Good.
Right, maybe one more question. So how many times this FMT should be given to this patient? Is it like only one time, or will they receive it more during the trials?
So there is no clear guidance. In the studies, they usually repeat this daily for 7 days. 1 time a day for 7 days.
For 7 days. And you mentioned your studies came only from 2 countries.
Yes.
Which are these 2 countries, and why do you think only in these countries? Is it because of the cost, for example?
I think this is not widely, so it's mentioned in ASLD American guidelines. However, it's not widely known intervention for this disease. So I think that's why it was picked up just by 2 countries that have most experience with this, and the countries are India and Slovakia.
Actually, Zoltan is very shy on this because he deals with microbiota, although that's mainly on kind of inflammatory bowel kind of issues. So I wonder if this is at least a little mysterious to me. I mean, in the morning we also had some kind of discussion that it could not be only negative factors, that maybe there are some pro-life signals are coming from the microbiota. I don't know if there is any clue on that. So not only harmful factors in response to kind of bad inflammation, but maybe actually again pro-regenerative signals coming from this. So I don't know if are there any data on this?
Yes, so there are some ideas that, for example, some metabolites like butyric acid, etc., could have an beneficial effect on hepatocytes. However, this is just very low evidence so far.